লাস্ট অ্যাড্রেনার্জিক ড্রাগস উপরে ক্লাস শেষ হয়েছে, অ্যাড্রেনার্জিক ড্রাগস অ্যান্ড অ্যান্টি অ্যাড্রেনার্জিক ড্রাগস. Today the class is on cholinergic drugs. The class will be taken in two parts. Today we will be discussing on the general consideration of the autonomic nervous system, on the cholinergic transmission and the cholineceptors. And tomorrow's class will be taken up by Dr. Anol on the cholinergic drugs and the treatment of glaucoma. We know that autonomic nervous system and somatic nervous system, these are the two parts of the nervous system. Somatic nervous system, they deal with basically voluntary works, while the autonomic nervous system largely basically functions below the level of consciousness. They are controlled involuntarily and they control visceral function. Now, what are difference between the somatic and the autonomic nervous system? The somatic nervous system, they supply skeletal muscles, while the autonomic nervous system, they supply all the other organs. The distal most synapse in the somatic nervous system is within the central nervous system, while in case of autonomic nervous system, they are in the ganglia. Nerve fibers, they are mostly myelinated, while in case of autonomic, the preganglionic fibers are myelinated and the postganglionic fibers are non-myelinated. The peripheral plexus formations are absent in somatic nervous system while they are present in autonomic nervous system. The primary efferent transmitter in the somatic nervous system is only acetylcholine, while in case of autonomic nervous system, they are acetylcholine and noradrenaline. These are the major neurotransmitters. Effect of nerve section on organ supply causes paralysis and atrophy of the muscle in the somatic nervous system, while the activity is maintained in case of autonomic nervous system. The autonomic nervous system pathway can be divided into three parts. One is the afferent, the number two is center, and the number three is efferent fiber. Coming to autonomic afferents, they carry mostly the mixed nerves. They are non-myelinated visceral afferent fibers. Now, the cell bodies of these afferent autonomic afferents are located in the dorsal root ganglia of the spinal cord and in the sensory ganglia of the cranial nerves. Like in case of vagus, one of the ganglion is the nodose ganglion. They mediate visceral pain as well as cardiovascular, respiratory and other visceral reflexes. Coming to the central autonomic connections, we know it lies in the central nervous system, but considerable intermixing of the innervation of somatic and autonomic nervous system occurs here. The main seat of the highest seat regulating the autonomic function is in the hypothalamus, that has got four nuclei: anterior, posterior, lateral and medial. Posterior and lateral nuclei are primarily sympathetic in nature, while the anterior and medial nuclei are primarily parasympathetic in nature. Many autonomic centers like pupillary, vagal, respiratory, they are located in the midbrain and the medulla, midbrain, pons and medulla. The lateral column in the spinal cord, they contain cells which give rise to the sympathetic outflow. Coming to the autonomic efferent fibers, they contain sympathetic and parasympathetic fibers. Many organs receive both the innervation, but there are certain organs which receive only one type. For example, most of the blood vessels, spleen, sweat gland and hair follicles, they receive only sympathetic innervation. Again, ciliary muscles, bronchial smooth muscles, gastric and pancreatic glands, they receive only parasympathetic innervation. And the two subdivisions, that is the parasympathetic and sympathetic divisions, they are majorly antagonistic in nature, but not all time. Like the refractory period of the atrial fiber is shortened by both sympathetic and parasympathetic stimulation. Now, difference between sympathetic and parasympathetic division: origin dorsolumbar from T1 to L2 in case of sympathetic, and for parasympathetic is craniosacral 3, 7, 9, 10, S2 to S4. Distribution is wide, while parasympathetic limited to head, neck and trunk. Ganglia in case of sympathetic nervous system is located away from the organ supplied, while is close to the organ in case of parasympathetic. As the ganglia are away from the organ supplied, the postganglionic fibers are long in case of sympathetic, and reverse, that is in case of parasympathetic, postganglionic fiber is short. Neuroeffector transmitter in case of sympathetic, the major one is noradrenaline in case of sympathetic. The others are also there like ATP, NPY, that is neuropeptide Y, dopamine, acetylcholine. The major neurotransmitter in case of parasympathetic is acetylcholine. Others like VIP and NO are also there. Stability of transmitter: noradrenaline is very stable, and it, after the action is over, it diffuses for wider actions. While acetylcholine is not stable, after the action is over, it is rapidly broken down to choline and acetate. Important functions: for sympathetic, tackling stress and emergency, and for parasympathetic, assimilation of food and conservation of energy. These are all from the previous physiology classes. Coming to the enteric nervous system. The enteric nervous system has been completely differently subclassified in the autonomic nervous system. Why? Because it receives innervation from sympathetic and parasympathetic nervous system, and again it has the capability to generate its own impulse. So, it is located in the gut wall. It has got two types of plexus: Meissner's plexus or submucosal plexus and Urbach's plexus. They have got afferent and efferent neurons as well, whose fibers travel anterograde, retrograde as well as in a circular manner. Receives input from both sympathetic and parasympathetic division. In addition, they function independently to integrate bowel movements as well as regulate secretion and absorption. That means if the autonomic and parasympathetic innervations are cut down, even then some of the action of the gut will be preserved. As such, it has also been labeled as a distinct enteric nervous system. Now, these are general outlay of efferent autonomic nervous system. Coming to the somatic one, the motor neuron, the primary neurotransmitter is the acetylcholine. They are functioning at the nicotinic receptor in the skeletal muscle. Parasympathetic, the primary preganglionic neurotransmitter is acetylcholine, and the postganglionic neurotransmitter is also acetylcholine, functioning at muscarinic and nicotinic receptor. And in case of sympathetic one, the preganglionic neurotransmitter is acetylcholine only. The postganglionic neurotransmitter, the major one is noradrenaline, acting on the alpha and beta receptor. Cholinergic, acetylcholine is the minor neurotransmitter, and in case of adrenal medulla, the preganglionic neurotransmitter is acetylcholine, and the catecholamines are released in the blood. Coming to the neurohumoral transmission. Neurohumoral transmission implies that nerves transmit their message across synapses and the neuroeffector junctions by the release of humoral or the chemical substance called neurohumoral transmitter or the neurotransmitter. Now, a chemical to be classified as neurotransmitter, that should basically have certain criteria. Number one, it should be present in the presynaptic neuron to be called as a neurotransmitter, usually along with the enzymes synthesizing it. Number two, it should be released in the medium following nerve stimulation. These are the criteria to be so that we can classify that this substance is a neurotransmitter. Number one, it should be present in the presynaptic neuron with the enzyme synthesizing it. Number two, it should be released in the medium following the nerve stimulation. Number three, its application should produce response similar to that of nerve stimulation. And number 4, its effect should be antagonized or potentiated by other substance which similarly alter the effect of nerve stimulation. Now steps in neurohumoral transmission. Number 1 is impulse conduction, transmitter release, transmitter action on post-junctional membrane, post-junctional activity, and lastly termination of the transmitter function. Impulse conduction. We all know that the resting membrane potential of a neuron is minus 70 millivolt. And how it is established? It is established by low sodium permeability and high potassium permeability, along with the active extrusion of sodium ion from the neuron. Now what happens? When an electrical impulse is generated, there is a sudden increase in sodium ion permeability. Sodium ion permeability বাড়ার জন্য কি হবে? Basically more and more sodium will move out. There will be depolarization. The membrane potential of the neuronal membrane will become more positive, around 20 millivolt, because of the basically shifting of the electromembrane potential. Potassium ions start to move out so that the repolarization can be achieved. The ionic gradient finally is normalized in the refractory period by the sodium potassium ATPase pump. Impulse conduction, the action potential thus generated, it sets up a local circuit current which activates ionic channels at the next excitable part of the membrane. For example, next node of Ranvier in the myelinated fiber, and the action potential is thus propagated without decremental response. Tetrodotoxin and the saxitoxin, they selectively abolish the sodium conductance or sodium permeability, and thus they block impulse conduction. Coming to the transmitter release, the action potential has been generated. Now what happens? That neurotransmitter that is stored in the pre-junctional nerve endings. Neurotransmitter গুলো কিন্তু pre-junctional nerve ending এ synaptic vesicle এর মধ্যে স্টোর করা থাকে. Nerve impulse, when the action potential is generated, what happens? There is a fusion of the synaptic vesicular membrane with the axonal membrane. How? Because of the calcium entry which fluidizes the membrane. Now what happens? Due to the fusion of the synaptic vesicular membrane and the axonal membrane, there is exocytosis of the vesicular contents that include neurotransmitters, enzymes, and other proteins. The release process can be modulated by the neurotransmitter itself or by the other agents that act through specific receptors on the presynaptic membrane, prejunctional membrane. For example, noradrenaline release can be inhibited by noradrenaline itself by the action at the alpha 2 receptor present in the prejunctional membrane. It can also be inhibited by dopamine, adenosine, prostaglandins, and enkephalins by acting at specific receptor, while isoprenaline acting on the beta 2 receptor and angiotensin 81 receptor causes increase in noradrenaline release. So noradrenaline basically নিজের রিলিজটাকে ইনহিবিট করছে বাই আলফা 2, বাড়িয়ে দিচ্ছে বাই বিটা 2 অ্যাকশন. Similarly, alpha 2 and muscarinic agonists, they inhibit acetylcholine release, but this action is not there in ganglia and the skeletal muscle. Now transmitter action on the post-junctional membrane. Now the neurotransmitter has been released. They are able to act on the receptor, a specific receptor on the post-junctional membrane. Then what happens? Two types of response may occur depending on the nature of the neurotransmitter, excitatory or inhibitory. One is excitatory post-synaptic potential, that is EPSP, and one is inhibitory post-synaptic potential, that is IPSP. What does EPSP do? Excitatory postsynaptic potential. They causes increase in permeability of the cations. So sodium or calcium influx occurs through fast or slow channels. They cause a depolarization. After depolarization, there is potassium efflux, so that the membrane potential can be maintained. These ionic movements are passive as the flow is down the concentration gradient. What happens in IPSP? IPSP, the membrane becomes more permeable to the anions. The chloride ions move in. Also, the IPSP can be maintained by increased permeability of the potassium ion. In addition, a trophic influence on the junctional morphology and functional status is exerted by the background basal release of the neurotransmitter. It is not that action potential is generated, then only neurotransmitter will be released. Even if there is no action potential, there is basal release of some neurotransmitter always, and that is responsible for the trophic influence on junctional morphology and functional status. Now, what happens? EPSP is generated. Now, EPSP, if it is above the threshold level, then only a propagated post-junctional action potential will be generated. Neurotransmitter is released even in the absence of the action potential in the basal small amount. Now, that is not sufficient to generate basically post-junctional action potential. When in presence of the nerve impulse, sufficient amount of neurotransmitter is released, there is supra-threshold EPSP generation, that is causing propagation of the post-junctional action potential, which causes basically nerve impulse in neuron. It can cause contraction in the muscle, it can cause secretion in the glands. And IPSP stabilizes the post-junctional membrane and they resist depolarizing stimuli. Now, these are schematic diagram you see is the pre-junctional membrane. Here the neurotransmitter, excitatory neurotransmitter is present. Now what happens? The excitatory neurotransmitter is released and they bind to the receptor at the post-junctional membrane. What happens? There is increase in the sodium permeability, that is leading to the generation of EPSP, depolarization. Now, due to the increased sodium permeability, potassium starts going out. Now, this is all the mechanism of the EPSP. Now, there is a presynaptic neuron which contain inhibitory neurotransmitter. When it is released, it acts on the specific receptor on the postsynaptic membrane. Chloride ion permeability is increased. So, what happens? It hyperpolarizes the membrane. Membrane is stabilized and is refractory to the excitable stimuli. Also, the potassium is coming out. Now, coming to the transmitter action. Neurotransmitter has been released. It has acted. Now, its action has to be terminated. Following its combination with the receptor, the transmitter is either locally degraded, like in case of acetylcholine, or it may be taken up back by the pre-junctional neuron and partly diffuses away, like in case of noradrenaline. So, these are the fate of the neurotransmitter. Specific monoamine transporter proteins are present in the pre-junctional membrane, like NET, norepinephrine transporter, ACRT, serotonin transporter, DAT, dopamine transporter. So, these are expressed on the axonal membrane for this purpose, so that the neurotransmitter can be taken up by the presynaptic neuron. The rate of termination of transmitter action governs the rate at which responses can be transmitted across the junction. Now, there are also amino acid transmitter other than noradrenaline and acetylcholine, example glutamate and GABA. They are also partly taken up by the active transport into the neuronal and neighboring GABA cells, glial cells. In case of peptide neurotransmitter like vasoactive intestinal peptide, like neuropeptide Y, enkephalins, they no active reuptake occurs, but they diffuses away and broken down by the enzyme peptidase. So you see, it's a diagram. Here the basic transmitter is acetylcholine, that is broken up by acetylcholinesterase into acetate and choline. Now again, when noradrenaline is the neurotransmitter, it is taken up by the norepinephrine transporter NET, and partly noradrenaline diffuses away. Now is an amino acid transmitter containing GABA. GABA is actively taken up by the GABA transporter GAT, and they partly diffuses away, and some are taken up by the gliases. Coming to co-transmission, we have learnt about the neurotransmission by acetylcholine and by noradrenaline, but one receptor, one neuron model is not sufficient. Other neurotransmitters are also present there, like VIP, as discussed, NPY, ATP and others. So it has become apparent that classical one neuron, one transmitter model is an oversimplification. On stimulation, most peripheral and central neurons have been shown to release more than one active substance. In the autonomic nervous system, primary transmitters acetylcholine and noradrenaline neurons have also been found to elaborate purines like ATP, adenosine, peptides, VIP, NPY, substance P, enkephalins, nitric oxide and prostaglandins as neurotransmitters. In most autonomic cholinergic neurons, VIP is also associated with acetylcholine, while ATP is associated with both acetylcholine and noradrenaline. NPY is more associated with noradrenaline. The transmitter at some parasympathetic site is nitric oxide, and these are called nitronergic nerves. Vascular adrenergic nerves also contain neuropeptide Y that causes long lasting vasoconstriction. The co-transmitter is stored in the same presynaptic neuron where the primary neurotransmitter is stored, but in the different synaptic vesicles away from the synaptic membrane. Although ATP is stored with noradrenaline in the same vesicles. On being released by the nerve impulse, what does they cause? Co-transmitters, either they modulate the release of the primary neurotransmitter, or they modulate the action of the neurotransmitter at the postsynaptic cleft, or they act as an alternative transporter, or they exert a trophic influence on the synaptic structures. Now, non-adrenergic, non-cholinergic transmission, where the transmission is mediated not by the acetylcholine, not by the noradrenaline. So, non-adrenergic, non-cholinergic transmission has been demonstrated in the autonomic innervation of the gut, vas deferens, urinary tract, salivary gland and certain blood vessels, where nerve stimulation is able to evoke a response even in the complete or total adrenergic and cholinergic blockade. For example, it has been shown that stimulation of sympathetic nerve to the guinea pig vas deferens elicit a biphasic contractile response. The initial short lasting contraction is elicited by ATP, by P2 receptor, purine 2 receptor, and the second longer lasting phase is maintained by noradrenaline acting via alpha 1 receptor. The time course of action of primary transmitter and the co-transmitter are different. For example, VIP produces a slow and long lasting response, while nitric oxide has an intermediate time course of action between VIP and ACH. Moreover, co-transmitters like nitric oxide, VIP, NPY they diffuse to a wider area and can affect receptors at some distance from their site of action. Now coming to the cholinergic drugs, cholinergic transmission. Acetylcholine is the major neurohumoral transmitter there. Now sites of cholinergic transmission, all postganglionic parasympathetic nerves, they contain acetylcholine as neurotransmitter. Even some postganglionic sympathetic neurons, they also contain acetylcholine, like sweat gland, some blood vessels. The type of receptor is muscarinic. The cholinergic receptor are of two types, muscarinic and nicotinic. So here mainly muscarinic, selective agonist muscarin and selective antagonist is atropine. Ganglia, both sympathetic and parasympathetic, they contain basically acetylcholine acting via nicotinic receptor. Selective agonist is DMPP dimethyl phenyl piperazine and selective antagonist is hexamethonium. Skeletal muscle, NM receptor is one of the subtype of nicotinic receptor. Selective agonist PTMA phenyl trimethyl ammonium and the selective antagonist is D-tibocurarin. এটা কিন্তু আমরা সব পড়ব পরে অ্যান্টিকোলিন ড্রাগে। Central nervous system, cortex, basal ganglia, spinal cord and other sites, they contain both muscarinic and nicotinic receptor. Now coming to the synthesis, storage, release of acetylcholine. How the acetylcholine is synthesized? It is synthesized from choline. What happens? Choline is actively taken up by the axonal membrane by the transporter, sodium choline transporter. After taken up by the presynaptic neuron, what happens? They are acetylated with the help of ATP and coenzyme A via the enzyme choline acetyl transferase present in the exoplasm. Now hemicholinum, it blocks the uptake of choline from the presynaptic neuron and thus is the rate limiting step in acetylcholine synthesis. So ATP plus acetate plus coenzyme A, acetyl coenzyme A. Now choline is taken up by the presynaptic neuron and in the presence of acetyl coenzyme A via the enzyme choline acetyl transferase, acetylcholine is synthesized and coenzyme A is liberated. Now storage of acetylcholine. After the acetylcholine has been synthesized in the presynaptic neuron, most of the acetylcholine is stored within a small clear synaptic vesicles which align closely with the junctional membrane. Now active transport of the acetylcholine into the synaptic membrane or into the synaptic vesicle basically is affected by a vesicle associated transporter VAT and that is blocked by vesamicol. The cholinergic action also contains some large dense core vesicles. They contain basically co-transmitters like VIP and they are present away from the synaptic neurons. Release of acetylcholine from nerve terminals occurs in small quanta in pulses by exocytosis. In response to a nerve action potential, there is synchronous release of multiple quanta triggering post-junctional events. Two toxins interfere with cholinergic transmission by affecting release. Number one is botulinum toxin. Botulinum toxin, they inhibit the release of the acetylcholine. And number two is black widow spider toxin. They cause massive release of acetylcholine so that the acetylcholine is depleted. Coming to the destruction of acetylcholine, acetylcholine is broken down into choline and acetate by the enzyme cholinesterase. Immediately after release, acetylcholine is hydrolyzed by enzyme cholinesterase. Now these cholinesterase enzymes are of two types, true acetylcholinesterase and pseudo acetylcholinesterase. Pseudo is also called butyryl cholinesterase. A specific or true acetylcholinesterase basically they are located at all cholinergic sites and they serve to inactivate acetylcholine instantaneously. It causes fast hydrolysis of acetylcholine, while the pseudocholinesterase or the butyryl cholinesterase, they are present in plasma and somewhere else in the body, and they serve to metabolize ingested ester. They cause hydrolysis of acetylcholine, but that is slow, very slow. So, true cholinesterase, they are present at all cholinergic sites, RBC and grey matter, while pseudocholinesterase, they are present in plasma, liver, intestine and white matter. Hydrolysis of acetylcholine is very fast with true cholinesterase, but that is slow by butyryl cholinesterase. True cholinesterase, they cause slower hydrolysis of methacholine, while they are not hydrolyzed by pseudocholinesterase. Benzoyl choline, they are not hydrolyzed, benzoyl and butyryl choline, they are not hydrolyzed by true cholinesterase, but they are hydrolyzed by pseudocholinesterase. True cholinesterase, they are more sensitive to physostigmine, anticholinesterase, while butyryl cholinesterase, they are more sensitive to organophosphates. They cause true cholinesterase, they cause termination of acetylcholine action, while pseudocholinesterase, they cause metabolism or hydrolysis of ingested esters. These are cholinergic neurotransmission or mechanism. Basically the choline is actively being taken up by the sodium choline transporters in the presynaptic neuron, and they basically in the presence of the acetylcholinesterase, acetylcholine is synthesized, that is actively taken up by the synaptic vesicle by the vesicle associated transporter, that is blocked by vesamicol. Acetylcholine is released in the presence of the nerve action potential and they act on the muscarinic and the nicotinic receptor. Now this acetylcholine, after their action is over, either they act at the muscarinic receptor in the presynaptic neuron, or they are broken down by the acetylcholinesterase to acetate and coenzyme A. Now coming to the cholineceptors, there are two types of cholinergic receptors, muscarinic and nicotinic. Muscarinic receptor, they are basically of 5 subtypes, M1 to M5, M1, M2, M3, M4, M5, and nicotinic, there are 2 subtypes, NM receptor and NN receptor. Muscarinic receptors are G protein coupled receptor and nicotinic receptors are ligand gated ion channels. Okay. Now muscarinic receptors, they are stimulated by muscarine and blocked by atropine, not nicotine. So these receptors are selectively stimulated by muscarine and blocked by atropine. They are located primarily on the autonomic effector sites of heart, blood vessels, eye, smooth muscle, gastrointestinal, respiratory and urinary tract glands, sweat gland and others, and in the CNS. Now functionally, pharmacological and molecular cooling technique, they have sub-classified muscarinic receptor into M1, M2, M3, M4 and M5. Of them, M1, M2, M3, they are the major, are the primary muscarinic receptors, while M4, M5, they have got lesser significance. M4, M5, they are present mainly on the nerve endings in certain areas of brain and regulate the release of other neurotransmitters, while the major muscarinic receptors, they are present on the effector cells as well as on pre-junctional nerve endings and are expressed both in peripheral organs and in CNS. M1, M4, M5, they are basically GQ protein coupled receptor, are of the same class, while M2 and M4, they are GIGO protein coupled receptor. Now muscarinic agonists have shown little subtype selectivity, like muscarine, they basically agonizes all the muscarinic receptors. So, but some relatively selective antagonists have been produced. Like for M1 there is pyrangiepine, telangiepine. For M2 the selective antagonist is basically triptyramine, while for M3 is dariphenacin, solifenacin. Most organs generally have more than one subtype, but one subtype predominate. Coming to the M1 receptor is present mainly on the ganglion cells in the enteric nervous system and the central neurons. It plays a major role in gastric secretion, ileus relaxation, intestinal secretion and in learning, memory, motor function. So, they are mainly present in the brain and the stomach. M2 receptor mainly present in the heart and they cause bradycardia. Vagal stimulation, bradycardia. So, they cause bradycardia. Autoreceptors on cholinergic nerve endings are also of M2 subtype. Now, smooth muscles express some M2 receptor along with M3 receptor and causes contraction. So, M2 receptor mainly present in the heart causing bradycardia. They can also be present, certain amount are present in smooth muscle causing contraction, but mainly M3 is there, and they are also present in the as autoreceptors in the prejunctional neurons. M3 receptors, they are present in the visceral smooth muscles and in the glands. They elicit contraction and secretion. Together, the M2 and M3 receptor mediate most of the well recognized muscarinic action, including the contraction of lower esophageal junction or sphincter. So, M1 receptor কোথায় আছে? M1 receptor. What are the subtypes of muscarinic receptor? কে বলবে বলো? বল, জোরে বল। Cholinergic receptors দুটো সাবটাইপ আছে, muscarinic and nicotinic. muscarinic এ 5টা সাবটাইপ রয়েছে। M1 পিছনটা থার্ড বেঞ্চ সেকেন্ড। muscarinic রিসেপ্টরে কি কি সাবটাইপ আছে বল, দাঁড়িয়ে বল। আসছি। তো কি বলছি রে, দাঁড়া, তো কি বলছি, কোলিনার্জিক রিসেপ্টর কি কি টাইপ আছে বল। কবার বলতে হবে? সেকেন্ড, নেক্সট। কোলিনার্জিক রিসেপ্টরস কি কি টাইপস আছে? নেক্সট, এটা সেকেন্ড টাইম বলেছিলাম আমি। নেক্সট, নিকোটিন মাস্কারিন, গুড। শুনতে হবে তোরে, এগুলো বেসিক কোয়েশ্চেন রয়েছে, এগুলো কিন্তু কোয়েশ্চেন কিন্তু ভাইভাতে আনসার করা হয় না। বসিয়া, নিকোটিনিক রিসেপ্টর কি কি টাইপ আছে? নিকোটিনিক বলছি। বল, নিকোটিনিক কি কি টাইপ আছে? হ্যাঁ, অ্যালফা 1 অ্যালফা 2 বোধহয় কোন রিসেপ্টর আছে বাবা? অ্যাড্রেনার্জিক নিউরোট্রান্সমিটার চলে গেছিস। NMNN করেছি, দিমাগটা কোথায় আছে রে? বসিয়া, NMটা কোথায় থাকে? ওটা হয়নি। হ্যাঁ, M1 রিসেপ্টর কোথায় আছে? M1 একজন বল। স্টমাকে থাকে, আর কোথায় থাকে? CNS এ থাকে। M2টা কোথায় থাকে? হার্টে থাকে। কি করে? ব্র্যাডিকার্ডিয়া করে, গুড। M3 কোথায় আছে? স্মুথ মাসল গ্ল্যান্ডস, যে কোনো গ্ল্যান্ডে সিক্রিশন করে, কন্ট্রাকশন করে। So, characteristics of the important subtypes of muscarinic receptor. Now, coming to the M1, they are present in the autonomic ganglia, in the gastric gland and in the central nervous system. Now, in the autonomic ganglia, what they are causing? They are causing depolarization resulting in generation of late EPSP. In gastric gland, they cause histamine release, they cause acid secretion. Now, in the CNS, they are responsible for learning, memory and motor fluctuation. Is the GQ protein coupled receptor, already পড়েছি M1, M3, M5. These are GQ protein coupled receptor. So, it's a GQ protein coupled receptor. GQ মানে কি করবে? IP3 DAG pathway, already receptor এ পড়া হয়েছে. So, IP3 DAG will increase, there is increased cytosolic calcium ion, phospholipase A2 will increase and lastly prostaglandin synthesis. Selective agonist oxotremolin and selective antagonist pyrangiepine, telangiepine. As M1 receptor is present in the gastric gland resulting in acid secretion, initially pyrangiepine, telangiepine were used to treat the peptic ulcer patient, that are not used nowadays because of more side effects, many side effects, and relatively safer drugs are used. Coming to M2, they are primarily present in the heart. In the SA node, they cause hyperpolarization. They are basically GO, GI type of receptor. So, they are basically inhibitory transmitter. So, SA node, hyperpolarization, decreased rate of impulse generation. In the AV node, decreased velocity of conduction. In the atrium, shortening of the action potential duration and decreasing the contractility. In the ventricle, cholineceptors are very sparse, the action is very few. So, decrease contractility only slight. Coavendings, they decrease the acetylcholine release. In the CNS, they are responsible for tremor and analgesia and the visceral smooth muscle contraction, although the M3 action is predominant more in the visceral smooth muscle. Is the GI-GO protein coupled receptor resulting in potassium channel opening and decrease in CAMP. Selective agonist is methacholine and selective antagonist is methotrexate and trimipramine. M3, they are primarily present in the visceral smooth muscle causing contraction. In the eye, in iris, they cause constriction of pupil, ciliary muscle contraction, exocrine gland, they cause secretion. In the vascular endothelium, via the release of nitric oxide, they cause vasodilatation. Is the GQ protein coupled receptor, IP3 DAG pathway, prostaglandin synthesis. Selective agonist is beta-nicol and selective antagonist dariphenacin, solifenacin. Nicotinic receptor, they are selectively activated by nicotine and blocked by tubocurarine and hexamethonium. Nicotinic receptors, these are the pentameric structure like rosette. So, it is a rosette like pentameric structure. এরকম থাকে রোজেট টাইপ, পাঁচটা বেসিক্যালি এটা থাকে ইউনিট থাকে. দে হ্যাভ গট এক্সট্রা সেলুলার ফেস, ইন্ট্রা সেলুলার ফেস. দ্য পেন্টামেরিক স্ট্রাকচার্স আর 2 alpha, beta, gamma or epsilon, delta in case of M receptor. Now, the ligand binding site is present somewhere between the alpha and beta subunit. When the ligand binds here, at the center there is a cation channel. When the ligand binds, the channel opens up and the ions move in. So, they are rosette like pentameric structure which enclose the ligand gated cation channel. Their activation causes opening of the channel and rapid flow of cations resulting in depolarization and an action potential. On the basis of location and selective agonist and antagonist, this nicotinic receptor can be of two subtypes, NM and NN. NM receptors, they are present at the skeletal muscle end plate and they are responsible for skeletal muscle contraction. They are selectively stimulated by the phenyl trimethyl ammonium and blocked by tubocurarine. NN receptors, they are present in the ganglionic cells in the adrenal medullary cells. They are also present in adrenal in spinal cord and in certain areas of brain. They are selectively stimulated by dimethyl phenyl piperaginium and blocked by hexamethonium. So, is the NM receptor present in the neuromuscular junction, depolarization of muscle end plate causing contraction of skeletal muscle. The has intrinsic ion channel, pentameric alpha 2, beta, epsilon or gamma or delta. Each subunit has got 4 transmembrane segments. What does it cause? After binding of the ligand, there is opening of the cation channel, sodium or potassium comes in. Agonist PTMA, nicotine, and antagonist tuberculin alpha bungarotoxin. NN receptor, they are present in autonomic ganglia and in the adrenal medulla and in CNS. Autonomic ganglia causing depolarization post ganglionic impulse. Adrenal medulla, they causes catecholamine release, and in the CNS site specific excitation or inhibition. It's again a pentameric structure. The channel is basically receptor is pentameric structure. Only alpha or alpha beta subunit is present. Opening of cation, sodium, potassium, calcium channels. Agonist DMPP, nicotine, antagonist hexamethonium, trimethophan. That's all. Next class তোমাদের cholinergic drugs এর উপরে হবে and treatment of glaucoma and myasthenia gravis.